Hello and good evening, everybody. My name is Alec. I'm the Managing Director of Wound Care People. I'd like to welcome each and every one of you to this evening's Facebook Live. This evening's session is called Pressure Injuries and Microworld, the animated way to learn. And I'm very pleased to introduce Elizabeth Faust, who's our speaker this evening. Hi, Liz.
Hello, how are you?
I'm very good, very good. Thank you very much for welcoming us. I know that we're in completely different time zones. So, Liz, you're a wound ostomy continence nurse practitioner over at Tower Health in West Reading, Pennsylvania. I've got that right?
Yes, yes, sir. Indeed, I am. So I'm over in the States right now.
Fantastic. Dark and gloomy Liverpool in a hotel room for me this evening. So,
Yeah.
yeah, very, very different indeed. Can I just start by thanking our partners at Microworld and Mölnlycke for supporting this event? This is the first Microworld event that I've hosted, and I'm really excited about it because this is we're going to be touching on the sixth module that we've released over the last sort of 18 months or so. And Liz and myself will give you some information on how you can sign up to those later on in the presentation. As always, certificates will be available at the end. And if you look on the side of your screen, wherever you're watching and on whatever device, you'll see there's a chat section there. Ask as many questions as you possibly can. We'll come back to do a live Q&A after Liz has finished the presentation. So please do engage as much as possible. Bear with us if there are any technical issues. We've done lots of tests, so everything looks fine. But we do have backup plans if something goes wrong. But we're not expecting that to happen. I think that's it from me. Thank you very much again for joining us. I'll be back after your presentation, Liz, to go through the live Q&A. In the meantime, I'll be keeping an eye on the questions and the comments, and look forward to catching up with you soon. Good luck.
Sounds great. Thanks, Alec. Appreciate it. I would also like to thank the Microworld Wound Care People and Mölnlycke for inviting me to participate. What a fun thing to do, a Facebook Live event. So I'm excited to talk to you guys today about pressure injuries and Microworld, which is obviously the new animated way to learn. So really, the end of this session, we're going to be able to understand how Microworld can offer you an animated way to learn and enhance your learning experience. We're going to understand what a pressure injury is and the categories of damage that can occur. We'll understand what factors make sense, make someone more likely to develop a pressure injury, and why it's so important to do risk assessment. And then the essential components of pressure injury prevention and management. And then obviously to explore a little bit more about what Microworld is, how to download the app and register. So what is Microworld? This Microworld is so fun if you haven't already seen it, but we all learn in different ways. And it's so important that teaching and educational materials really embrace everybody's different learning styles. As a wound care clinician, I'm very visual and I get bored easily. So this is a great way for me to capture my attention and remember it. But it's pretty non-traditional approach to learning. So with this, we can educate clinicians around the world. We complete the module, which you can use towards your revalidation, but each learning area opens up a different learning area. So you kind of expand and grow as you go along with it. And there's complex content that's delivered through really fun and engaging interactive animations. There's videos, there's games to play and illustrations. I don't know about you, I do Sudoku and Wordle every day. So I just add this to my list of fun stuff to do. So in the classroom so far, I think Alec mentioned that we'll be covering module 6, but there's 5 classes before that. So class 1 covers the process of wound healing, including anatomy of the skin, the 4 phases of wound healing. Class 2 offers the importance of wound exudate, how to assess and manage it, and how it helps heal wounds. And then class 3 covers the signs and symptoms of a wound infection, how to manage infections, and how to aid in wound healing. Class 4 covers the holistic wound assessment and management strategies needed to promote the healing of chronic wounds. And then class 5 covers the fundamentals of incision care, how to manage those surgical wounds and prevent a surgical site infection. So here's some of our characters. So we have Mr. X, who is XCD. We have Gluco, who's the glucose molecule. The Pro twins, which is protease enzyme and the inhibitor. Then you have the controller, which is the growth factor. And then we have the professor and a few other characters in there. So class 6 is what we're here to talk about. And the focus of this class is pressure injuries. We're going to play a short video for you. So you can see how fun this can be, really. So class 6, the class will take you through what a pressure injury is and the categories of damage that can occur, what factor makes somebody more likely to develop a pressure injury, and why risk assessment is so important. And then, of course, the essential components of not just prevention, but also management of pressure injuries. So let's dive into some of it. Sometimes they call them pressure ulcers, decubitus ulcers, pressure sores, or my favorite, bed sores. It's caused when an area of skin and tissue below the surface level are damaged, being placed underneath pressure, including pressure associated with shearing forces, not sufficient enough to impair the blood supply. Pressure injuries are painful, they're costly, they have detrimental effect on patients' quality of life. They increase the risk of infection, they prolong hospital stays, and they can even result in death. So pressure injuries can occur as a result of two forces in action. So there's direct force of sustained pressure, which can cause tissue ischemia in as little as 2 hours. And then there's the distortion of tissue when you have sustained pressure with shearing force. So shearing is kind of that back and forth motion, and it stretches and tears the tiny arterioles and capillaries within the skin and underlying structure, creating damage beneath the surface. So we categorize, in the UK you categorize, in the States we stage, but that's okay. So category 1 is intact skin to have localized areas of non-blanchable erythema. We're going to come back to that non-blanchable comment. Category 2 is partial thickness skin loss with exposed dermis, and it can be an open wound without much depth. It could also be a fluid-filled blister where the epidermis has separated from the dermis. Category 3 is a full thickness skin loss, and sometimes it has visible adipose, a little bit of slough. Sometimes there's undermining or tunneling, but there is no tendon, no muscle, no bone exposed. Then with category 4, you've gone all the way through full thickness tissue loss, exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, bone, or hardware in the ulcer. And the depth of these can really vary depending on the anatomical location. Obviously, the bridge of your nose is going to go down to bone much quicker than, let's say, your gluteus, where you have much more muscle or much more adipose tissue over top of it. Unstageable pressure injuries have significant depth, but you don't really know the full extent. You can't really see the base, and this could be because of blockage with slough or eschar tissue. Then there's the suspected deep tissue injury. So this can present in a variety of different ways. It could be intact or non-intact skin, but it's characterized by non-blanchable, persistent red, maroon, purple discoloration. It'll start to separate and look superficial, but that darker discoloration underneath the surface signifies that there's a deeper tissue damage that's underneath. They also can change quickly to a necrotic tissue as well. The other way they can present is as a blood-filled blister. Then you have this device-related pressure injury. And The device-related pressure injury is caused by a device or an object and is distinct from the pressure injury, which is primarily caused by body weight forces, but it's defined as an ulcer that involves interaction with the device or object that is in direct or indirect contact with the skin. Some examples include devices like face masks, endotracheal or nasogastric tubes, oxygen tubing, non-invasive ventilation masks, urinary catheters, cervical collars, orthopedic splints, but really could be anything, including non-medical related devices such as glasses. Just remember, when you have a device-related pressure injury, you still categorize it. You just also note that it's device-related. So some points for practice. Practical ways that that can be used to test for blanching and non-blanching erythema. So you want to apply light finger pressure to the reddened area and for a count of 3. If the area becomes white on removal and then returns to red, this is blanching erythema and signifies healthy skin. Non-blanching signifies that it should be categorized as a stage 1 or a category 1. You can also use clear discs to press against the skin so that you can observe the skin to ensure that it does actually blanch. If the skin is white beneath the plastic and it blanches, then it's healthy. When examining areas that are difficult, you might need to use mirrors or turn the patient so you can appropriately see. I am going to mention darker skin tones just at a later slide. So let's talk a little bit more about pressure injury prevention and management. There's some key principles for prevention. First, you should identify the risk and then obviously act upon that risk by preventing exposure to pressure and or shearing forces. The aim of pressure injury management is to promote wound healing while still alleviating that pressure to prevent any deterioration of the wound. For prevention and management, the general health of the patient should be optimized whenever possible. Pressure injury prevention and management can be split into several areas, but there's this acronym, ASKING, that can be used to plan and implement care within your clinical practice. So A is for assess risk. S is for skin assessment and skin care. S is for surface. K is for keep moving. I is for incontinence and moisture. N is for nutrition and hydration. And G is for giving information or getting help. So let's dive into this. Assessing the risk. Risk assessment is to determine your risk for pressure injury development. It's a clinical judgment, but there's also validated tools. Some risk assessment tools are Braden, Waterlow, Purpose T, depending on your local policy. An assessment of a pressure injury risk should be undertaken within 6 hours of admission to a healthcare setting, at first face-to-face in a community setting by clinical staff, or any change of condition, such as becoming unwell or experience a fall, or in a clinical setting at any opportunity. So if you see a patient in the clinic or in their home, you would want to note their skin assessment and their risk assessment while you're doing the rest of their assessment. Also, for assessing risk, there's 2 main factors. That's intrinsic, which is unique to the individual patient, and extrinsic, which are things we can hopefully act upon. Intrinsic are reduced mobility, inadequate nutrition and hydration, their age. Here it says over 65 years old, but I'm also going to put in a plug that our neonatal population is particularly at risk as well for their underdeveloped skin. Incontinent patients, medications, particularly corticosteroids, neurological disorders such as a stroke, or really any impairment in such as like neuropathy or a sensory impairment such as a spinal cord injury, infection and circulatory disorders, including temporary low perfusion related to an acute illness. Extrinsic factors are pressure, which can be related to restricted mobility or medical devices, casts or appliances. Shearing from either incorrect handling, techniques, friction, moisture, or a common one in my hospital setting is head of bed elevation. Temporary restricted movement, such as if you're paralyzed for a surgery or if you've had an epidural or local anesthetic that inhibits your capacity. The first S is for skin assessment and skin care. So you must undertake frequent skin inspection and identifying skin abnormalities. And really, you're just incorporating that skin inspection into your regular repositioning, changing clothes, or whatever personal hygiene you're providing to the patient. You want to use both visual and palpation for texture and temperature over a bony prominence. So non-blanchable or persistent erythema or discoloration of the skin that does not turn white is one clinically important skin abnormality that can be identified as part of that thorough skin inspection. Skin tone can affect presentation of early stage pressure injuries significantly. So dark skin rarely blanches to the response of pressing on it, and clinicians typically don't have specialty training that teaches us how to assess differently for a darker skin tone. In darker skin tones, for example, any changes in the skin coloration doesn't have to be necessarily erythema, should be noted and compared with the surrounding tissue or tissue on an opposite limb. For example, when you're inspecting the heels, look at both heels to see if they're similar in color. Patients with dark skin tone are more likely to be diagnosed with a higher category pressure injury because it's difficult to tell if they're progressed rapidly or if they were just not diagnosed when they were an earlier stage. The patient, therefore, other useful indications such as pain, warmer or cooler skin over that bony prominence, if it feels boggy or kind of mushy, or even hardened over that area. There's lots of indications that you can use, and we use kind of two consensus documents: best practice statement for addressing skin tone bias in wound care, how to assess signs and symptoms in people with dark skin tones, and that's from Wounds UK in 2021. And then in 2023, we have a document from Wounds called Wound Care and Skin Tone, Signs, Symptoms, and Terminology for All Skin Tones. As skin assessment and skin care, we also have that you want to look at the bony prominences because that's most often where they will occur, but of course, not always. The best shot is an acronym that you can use for this. So B stands for buttock, E stands for elbows and ears, S stands for sacrum, T for trocancers, S for spine and shoulders, H for heels, O for occipital area or other. I like to throw in the ankles for the malleolus there, and then T for toes. The second S is for surface. So support surfaces are one of the most common interventions for preventing pressure injuries in patients with reduced sensation or independent movement restrictions. Pressure injury preventing support surfaces can be divided into three main types. So you've got active or dynamic, and that's where it alternates between the pressure. There is pressure and contact with the skin by inflating and deflating cells. And usually that's with an electrical pump. So that's either an external pump to the bed or it's incorporated within the bed. Then you have reactive or static, which is a pressure redistribution over a larger surface area. So I always think of like a nail if you step on it versus a bed of nails if you step on it. It'll spread that pressure over a larger gradient to reduce the surface tension. An example of this is like a high specification foam mattress or cushion. Let's not forget about our seating options. And then support surfaces that just provide immersion. So immersion is like sinking into the support surface and then envelop it is that it conforms around you. So those are really the two principles that you want in a surface to help reduce the pressure to the bony prominences. The 2015 NICE guidelines recommend that at minimum, patients at risk should be cared for on a high specification pressure redistributing foam mattress and or cushion. All right, points for practice. So the support surface selection depends on a variety of things, obviously. The level of activity and mobility. So the less mobile and active, the higher grade support surface you'll need. What specific requirements they have. Do they have any special needs? Do they have good lateral trunk stability? What their weight and their size is. Do they need a bariatric one or a wider cushion or bed? If they already have a pressure injury, that can help you determine which level they should get, their level of risk, the impact on manual handling, meaning how you can reposition the patient's comfort, how well they do with repositioning, and then safety. So of course, they're at risk for falls. You want to ensure that you have safety measures as well. I think this is actually a multidisciplinary project. I include, the physiotherapist, the nursing specialists, occupational therapists, or rehab doctors. We're all involved in this conversation to determine what is best for the patient. So K is for keep moving. So pressure injuries are caused by the application of sustained pressure tissue. So keeping patients moving and repositioning them is so important for pressure injury prevention. But you also want to think about patients that move excessively. Do you have an agitated patient? Do you have a patient who shakes a lot from Parkinson's? Because bony prominences may still be exposed to pressure or shear even after you offload them. In all patients at risk for developing pressure injuries, manual handling aids should include equipment such as slide or glide sheets, hoists, and electric profiling beds to help reduce that sliding and shearing force. Patients at risk of pressure injury should also be repositioned unless contraindicated, and that can be done in a variety of different ways. Obviously, if the patient can safely self-reposition, that would be ideal, is to prompt the patient, help them with it. It's not always easy to have your patient reposition themselves without causing extra shearing, though. So if they need help, obviously help them. You try to utilize under that 30-degree tilt for their head of bed to help reduce that shearing and additional pressure. The electric bed frames can help, always putting the feet up before you put the head up. And then prone positioning can also help reduce some of that posterior trunk pressure. The frequency of repositioning is a hot topic, and I know there's ongoing research on it, but it should really be determined by the patient's individual risk and clearly determined by the healthcare team. So you need to determine a repositioning chart so that you're aware of the time and position of the patient and when they were moved. And then where appropriate, information and education should be provided to the patient, the family, and the caregivers, including nurses, providers, everybody. The I is for incontinence. So managing incontinence and high volumes of moisture, because incontinence increases your risk of moisture-associated skin damage. Moisture is not a direct cause of pressure injuries, but it can weaken the skin and increase the damage caused by friction and shear. So thus, it increases your risk of pressure injuries. Although assessing skin damage accurately is also really important because incontinence-associated dermatitis is often mistaken for superficial category 2 or 3 pressure damage and vice versa. So pressure injuries, when you're trying to look at them versus incontinence-associated dermatitis, you want the pressure injuries occur over a bony prominence or under a medical device. They occur in areas exposed to pressure and or shear. They tend to be painful, of course, unless you're lacking sensation. They usually have distinct wound edges and margins. The base may or may not contain non-viable tissue, and the presentation really varies. So it could be intact skin with non-blanchable erythema, or really full thickness tissue loss with potentially infection. Whereas incontinence-associated dermatitis usually occurs with urinary or fecal incontinence. It has distinctive pain. It occurs in different locations. So you could have it from an anterior surface all the way to a posterior surface. The pain is described as burning, itching, or tingling. It can affect perineum, perigenital, peristomal, buttock, gluteal fold, medial, posterior thighs, your lower back, really any bony prominences in that area. The affected area is usually diffuse and the edges are poorly defined, could be blotchy, could potentially have an associated skin infection with it, and sometimes with or without superficial skin loss. So why is this so important? So cleansing should take place as soon as possible when it comes to an episode of incontinence, because there's this very fragile pH balance. If you haven't heard of it, the acid mantle protects your skin from a transepidermal water loss. And so cleansing with soap can be really alkaline and can disrupt that acid mantle and the balance of the skin pH. Additionally, washing or vigorously scrubbing with washcloths can increase your friction and shear, which can further damage that epidermal layer. The principles of protection are to provide a barrier between the skin and the urine and feces to retain the moisture of the skin. So we're really trying to give our skin like an extra coat, like a raincoat, so that any urine or feces is repelled away versus being absorbed and damaging. So I think of my barrier creams as like a raincoat for my skin. So you can do this with moisturizer, with mild IAD. There's also skin protectants for more severe cases that allow the skin to recover as well. Some patients may even need that extra step in their skincare to help restore the skin's barrier properties. And that's like products that are left on the skin. It really all depends on how much they have out, how often you're having to change them, and things like that. So the other thing is that occasionally it's a wound that's causing the moisture. So if you have a lot of wound exudate, ensuring that you're having a high absorbency product, that you're protecting the peri-wound skin, that you're addressing any factors that could increase the drainage, such as a localized infection or bacterial burden. N is for nutrition. And I would say any patient with a wound, particularly a chronic wound, or a fistula or a sinus tract or something that has lots of exudate, will always be behind the 8 ball when it comes to nutrition. So again, important to screen, identify the risk, and then intervene upon that. Because nutrition and hydration have a major role with skin health. And so the assessment for nutrition really is part of the overall pressure injury risk assessment. There's also validated screening tools, such as like the Malnutrition Universal Screening Tool, otherwise known as MUST. And then for chronic wounds, it's really like a must-have, not a nice-to-have. Points for practice are food fortification and additional snacks should be the first line choice in meeting nutritional requirements. Sometimes that can be hard in patients who don't have much of an appetite or who have any eating difficulties. In that case, then supplements can prove invaluable for improving the outcomes for your patient with chronic wounds, especially pressure injuries. Clinical practice guidelines recommend the use of oral nutritional supplements containing both micro and macronutrients to help improve the pressure injuries in those patients who are malnourished. Nurses can play that key role in ensuring the nutrition and hydration are included as part of that holistic assessment, and help and support can be obtained from dietitians and your nutritional team. I know we have a really great team here. We send up our supplements on their breakfast, lunch, and dinner tray, and our aides know to take it off the tray immediately so that the patient can eat as much food as they can. And then we save the supplement for their in-between meals. G is for giving information and getting help. And the more I see legal case reviews in the US, I know that giving information to the family is super important, and to the patient, obviously. So information can help the patient understand the why of their treatment plan. It helps them participate more. You have to be clear and have a focused key message and use everyday language. Like, I'm going to turn you, I'm going to look at your skin, I'm going to press on your skin. You want to consider everybody's ability to learn, repeat it when you're doing it, just so the repetition helps it sink in, and then reinforce verbal information with pamphlets, writing, any handouts that you can offer. So when it comes to when a pressure injury develops, what do you do with that wound? So one highlight is that wound dressing should create a moist wound healing environment that supports that wound healing process. So assessing the wound and looking at the local wound management is just like any other chronic wound. You want to identify and treat the background disease. So if there's comorbidities, address those. Identify any wound-related factors that could delay wound healing, such as the presence of devitalized tissue, of bacteria, of exudate that's not being managed, and the peri-wound skin. The treatment can depend on the classification and the depth of the injury, involve the patient, family, caregivers, and always plan, implement, and reevaluate as appropriate. Our guidelines here, we typically reevaluate at minimum weekly, and then as needed, as guided by our nursing staff. And really, again, just to promote that moist wound healing environment. So management of the wound bed tissue type should include debridement of any non-viable tissue, such as slough or eschar, while protecting healthy granulation tissue or delicate wound edges. You want to manage the infection and biofilm, including the use of topical antimicrobial dressings to reduce the bacterial load. I think the one we see the most here in the US is silver. Exudate management. So when there's high volumes of exudate, we'll be using dressings that can absorb that, such as like a super absorbent or gelling fiber dressing. Pain management. So the often forgotten hero of it, avoiding pain and trauma at dressing changes can be done with products that have a silicone contact layer or a silicone foam dressing. Larger wounds or more severe wounds are also applicable for negative pressure wound systems, and the negative pressure system can also protect the wound from any external contamination. And then peri-wound skin management. So, obviously, if you don't protect the peri-wound and that gets damaged, really your wound just gets larger because you're causing damage to that skin level. So some conclusions, pressure injuries are painful, they're costly, and they have serious negative effects on a patient's quality of life. A pressure injury can be seen as intact skin or an open wound, so the severity really varies a lot between the categories. Identify those who are most at risk and implement a plan for prevention and management into clinical practice, which is just essential to their overall treatment plan. If a pressure injury is present, you want to make sure that you have a holistic wound assessment and that you have created a management plan that, in conjunction with the patient, family, caregivers, to address all of the needs of not just the wound, but of the patient as well. And then wound dressing should really be utilized to help create that moist wound healing environment and help support wound healing process. So at the end of our modules, you should be able to repeat and recap information. So the module can offer, what happens is once you've completed the module, it'll open up other learning areas on the site. So we'll introduce you to the different areas of the dashboard. You can access new content. You can view your activity, track how well you're doing. You can monitor and analyze performance for all of your personalized Microworld dashboard. Here's an example of the Moist game. There's also Skin Run, Exudate Swim, Infection Wars. Moist game, you really put your powers to the test and you kind of swipe. I don't know if you guys ever do like Candy Crush or anything like that, but you can swipe through the grid to prove you have what it takes to tackle those hard to heal wounds. So here's your call to action. To explore Microworld for free, you can download the app or you can sign up online to start exploring. You would just want to register at Microworld, which is www.mymicroworld.online/ to undertake the modules. And I again want to thank the Microworld, the wound care people, and Mölnlycke for asking me to come talk to you guys. And I think at this time, we're going to open it up to questions.
Sorry about that, Liz. I was just trying to unmute myself there. So I've been quiet, quiet in the background, just watching away. Thank you very much. Great presentation. And we've had lots of questions. I just want to repeat just quickly because there was a link that was put into the text. So if anybody clicked on the link earlier and it didn't work, the correct link is pinned at the bottom of the text section. There was just somebody had typed it, I think, very quickly, and it just made the a spelling mistake there. So it is. I'm being assured that it is the right link that is pinned to the bottom of the chat box. So we'll get on with the questions because they're still coming in, and then we can just recap sort of how people can get online onto Microworld and how they can use it. And we hope everybody enjoys it and shares it in the same way that you do. So the first question is, how do you categorize a healing pressure injury? Does it essentially go in reverse? For example, does a category 3 then become a category 2 and then a 1?
Yeah, so when you're categorizing them, obviously if the wound gets deeper, you would upstage the wound, meaning that you would go from like a 1 to a 4. However, once you've kind of gone that deeper level, it will always be at that level. So the next time you assess the wound, even let's say it's a stage 4 or a category 4, and you no longer see exposed bone, muscle, tendon, whatever was exposed before, you would not now say, oh, it's a stage 3 or a category 3. You're going to just say, oh, it's a healing stage 4, because once a deep wound, it'll always be a deep wound. You know, we never really get that same tissue quality or tensile strength back. So you always want to leave it at that more severe level.
Okay, and so this is so. Pardon my ignorance here, and this is standard across the world. So the fact that you're in Pennsylvania at the moment and I'm here in Liverpool, that makes no difference. That's standard across the world in terms
Correct,
of categories
yeah.
and staging, and then how you talk about them when they're starting to heal.
Well, we have this great document that is the National Pressure Injury Advisory Panel, which is America's. Yeah. We've got the European Pressure Ulcer Advisory Panel, which I'm so jealous is going to be over there shortly.
This starts tomorrow in Leeds. The reason I'm in Liverpool is we've got an event tomorrow, and then I'm heading to that. Yeah.
And then we also have the Pan-Asian. So we really have a world view of everybody, and our consensus document and our consensus guideline is kind of our Bible, if you will, for the treatment and prevention of pressure injuries. And that does include no backstaging, which is the term we use for when you're trying to give it a lesser category if it's already been at a higher category.
Okay, brilliant. Well, whoever asked that question is fantastic, because that's something that I've just learned today, because I just assumed that you would go from 4 back to 3 to 2 to 1 and whatever. Okay, so question number two. If you have a pressure injury on the heel in a diabetic patient, is it classified as a diabetic foot ulcer or a pressure injury?
No, so you always want to classify the wound based upon the etiology. So a classic diabetic foot ulcer will be on the plantar foot and the forefoot. And if you have a wound on the heel from the patient being exposed to sustained pressure, then that is ultimately a pressure injury just in a diabetic patient. So you would want to categorize that as the pressure injury. If your provider or a doctor or something, you can note that the patient is diabetic as well. But here in the States, we have this fabulous book. Do you see how thick it is?
Yeah.
Those are our codes for how we categorize. And so based upon our recommendations from what we have as the AMA, and from the multiple courses I have taken, I have to shout out Jeff Lehrman has taught me so much about how to code in order to get things appropriately paid for. But the correct thing to do is to call it based off the etiology. So it would be a pressure injury in a diabetic patient.
Okay. Okay, so question number three. If you're using a slide sheet to help move and reposition someone, should you remove it every time or can you leave it in place?
Yeah. So here at my institution, we utilize slide sheets that you can keep under the patient. You definitely want to check with the manufacturer of the slide sheet because they're not all made the same. So we actually utilize a slide sheet made by Mölnlycke, and it's intended to stay underneath the patient as you reposition. We utilize one that can be used with like a lift. It's called a sling. And so that is intended to stay under the patient. It's got a good microclimate, so it allows air to move through. It's permeable, so it doesn't cause excessive sweating. It doesn't have hard spots. It doesn't have bulky plastic built into it. There's other types of repositioning devices that may not be meant to stay under the patient. So definitely check with your manufacturer to ensure what the best practice is. But also ask them the questions, does this have an appropriate microclimate? Is it safe to reposition my patient with it and leave them under it and things like that?
Okay, there's quite a few questions that are coming in actually regarding sort of repositioning. So the next few are sort of variations on the same theme. So this one is quite specific. This one says, if someone had a grade 2 on their left buttock, would you reposition and offload that area completely, or I think it should be, or just offload the right side and on the back? Does that make sense? Shall I read that again?
Oh, no. I think I understand. So if you have a unilateral
Yeah.
pressure injury, should you avoid positioning onto it? I think is the more general statement.
Yeah.
So I would say that the concern there is that you'll put more pressure somewhere else. So obviously avoiding pressure to that area is part of it, but how well you're doing it. Because here at my institution, I know we have some pillows are this thick and some pillows are this thick. And so we try to reposition everybody with a wedge, but I reposition that same 90 pound patient as I do my 550-pound patient. So obviously the 550-pound patient is going to crush it a little bit more. So more so than avoiding one area, I would say that it's more important to appropriately give them that 30-degree repositioning to truly offload, to allow that tissue to have zero ischemia to it. We also started utilizing pressure mapping system, and it's really been awakening for the nurses to see that simply pulling a pillow out or pulling a wedge out doesn't truly reposition the patient, that they really have to readjust the sheets and ensure that the patient is positioned appropriately. So it's not an area where you want to cut corners. I don't think there's any specific guidelines in the document, in the NPIAP or the EPA UAP guidelines that say that you should inherently avoid repositioning to a side if there's a pressure injury there.
Okay. Okay, so how often then, so the next question is, how often should we be repositioning vulnerable patients? Which I think is more broad, really, as a question.
Yeah, so there's some really good literature that's being put out by Tracy Yap, who is studying repositioning and movement strategies in elderly population in skilled nursing facilities. So nursing homes is what we call them here, but it's patients who are residents there, so they live there, but they are being cared for by nurses and nursing assistants. So they look at the patients whose Braden scores are low enough that they're considered at risk, and they put them into categories. So this category we reposition every 2, this one every 3, this one every 4. And they're finding that at least in the skilled nursing facilities, so not quite as sick patients, that those patients can tolerate a little bit more pressure. And it also depends on how much sensory perception they have. So I think there's still some ongoing research for that. And I think, unfortunately, our best bet is right now is just frequent visual assessment. So if you're turning your patient every 2 hours and they're developing large areas of erythema, then maybe you should be repositioning more frequently, or you should be getting a better support surface that can handle that pressure redistribution for you. So while repositioning is the gold standard for pressure injuries, there's additional things you can do, such as silicone bordered foams and better support surfaces that can also help assist with that offloading.
Okay, thank you. So just to remind the audience that there's a lot of questions coming in. We're obviously not going to get a chance to go through all of them. And what we normally do or what we always do, is we'll take all those questions. And if we haven't had a chance to answer yours this evening, we put them into a document and we put the responses next to them. And then you can download that document next to a copy of this presentation, which you'll also be able to download from our website within the next couple of days. But we do have time for a couple more. The next 2 are really, really similar. So I'll sort of try and combine them because what the next questions are saying is, how often do we need to give positional changes to patients with pressure damage lying on pressure relieving mattresses? And then the next one is just talking about specific types of mattresses. So, it says it's the same thing. If a patient is on an air mattress or a tilting mattress or another type of mattress, do they still need to be repositioned as regularly?
Yeah. So I'll say for any of the mattresses, support surfaces, that you definitely do still have to reposition the patient if they're on that. I will say there are some devices out there that I know there are some companies that make a repositioning bladder that goes under the mattress that has been shown that it can reduce the pressure underneath. Those are available in the US and in Europe. I've seen them both at the EPUAP and at the NPIAP. They have a support surface plus a repositioning thing built into it. But the majority of our support surfaces, there's a company that has something called Turn Assist. And while that does, slightly reposition the patient, it doesn't do it enough to cause a full pressure relief of that integumentary system. Obviously, it also depends on how frail your patient is. So if you have a patient who is particularly frail, maybe they're in the ICU, they aren't able to communicate pain or pressure or move with discomfort, then those patients are going to be highly at risk for pressure injury development. So you need to do all the things. So you need to reposition. You need to put them on a dynamic, active support surface. You should use the silicone 5-layer foam dressings to help reduce that pressure. So I think the higher the risk, the more you have to do. And the less the risk, the less you have to do. So just because you put an intervention in place doesn't mean you stop the other interventions if they're high risk.
Okay, so a slightly potentially controversial last question from me.
Great.
And I'm not sure how big an issue it is in the States or statewide, but here in the UK, we have a serious problem that I think is well known. It's well documented in the news, and I'm assuming that the news travels outside of the UK with huge long wait times in our A&E departments, in our AD areas, where people are waiting in ambulances for long times, and people are waiting in hallways on beds while they're waiting to be seen with broken legs and all the rest of it. And we are hearing more and more about these people ending up with pressure damage because of the amount of time they're being left in this situation. I have some personal experience of a family member that went through something very, that basically ended up in that situation as well. I guess the question, after sort of pointing that out, because I think people recognise that is happening, how do we get this education out there about the importance of pressure damage to everybody that is interacting with a patient that is on some sort of surface for prolonged periods of time?
That's
And do
great.
you have that? Do you have that same problem in the States? I guess is the first thing. And how do you tackle it?
Yeah. Yeah, so I'll tell you, I don't think it's unique. I think our emergency rooms are overwhelmed, particularly when we get into flu season. We see that there's longer wait times, and when there's a lack of beds. Certainly, COVID created its own little monster that caused this bottlenecking of the systems where, we had patients stuck here in the hospital. We couldn't get them out to rehab facilities. There was lots of patients in the ED. That's what we call boarders when they're down in the emergency room for an extended period of time. We recognized that there was some complications that some of our patients suffered from staying on these smaller litters or the smaller mattresses for an extended period of time without the capacity to be appropriately offloaded. So we actually started a frailty team in the emergency room that helps educate their staff in recognizing patients who may be at risk for developing pressure injuries. So for us here, we do our risk assessment historically when the patient gets admitted to the ward or the nursing unit. Or to the operating theater, if they go right there, we do a skin assessment before we start. And what we were able to do was we were able to stock like air cushions and kind of support surfaces that were a little bit more temporary, not as expensive. We were able to stock the silicone bordered dressing so that there was something in place for those patients. And then in areas where the patient stayed over 12 hours, we got regular hospital beds that had pressure redistribution surfaces on them. So, and then we did certain things like if it was a hip fracture, all of those patients had orders for heel elevation, like off the support surface immediately, because depending on how long they needed to wait to go to the theater to get their hip repaired, they could have a significant heel pressure injury by the time they do that. So using our medical record system and our documentation to help elevate the best practice guidelines into effect at time of entry.
Okay. Well, I'm looking forward to spending a bit of time at the EPUAP conference over in Leeds this week to find out what else is happening in the world of pressure injury and pressure injury care. But for now, I think that's probably the last question. I just want to thank thank you, Liz, first and foremost. And to thank my team at Wound Care People for working on this for the last couple of weeks, and our colleagues over at Microworld and Mölnlycke. Looking forward to seeing those over the next couple of days. Don't forget, you can download your certificate for your CPD files for revalidation purposes now. There should be a link in the comments section, as well as the My Microworld link. So just a reminder, it is www.mymicroworld.online, and then a / that'll take you to a registration page where you can register, have a check out some games. A really important thing is that you can play against your colleagues. So you basically, every time you play a game, you get scores. So it becomes it becomes very, very competitive. We do it as a team quite a lot. As the new games come out, we're always playing and seeing who can get the highest score. Thank you very much for giving us your time this evening. To our wonderful audience, as always, please enjoy the rest of your evening and keep an eye out, because we'll be back in a couple of weeks with another Facebook Live on one of our channels. And I think that's it. Thank you, everybody. If I haven't thanked anybody specifically, then I do apologize, and I'll message you later privately. But thank you very much, Liz, and I look forward to working with you again soon.
Okay.
Good night, everyone.
Night.